Arterial and Venous Blood Gas Analysis in Critical Care by Dr. Edward M. Omron, MD, MPH, Pulmonary and Critical Care Medicine. The arterial blood gas and mixed or central venous blood gas are mainstays of diagnosis and therapy in acute severe illness. Historically, they have been viewed as separate but not equal bedside tools. The venous blood gas has been used as a surrogate measurement of arterial pH and or arterial PCO2, as a separate measurement to determine mixed or central venous saturation, SVO2, or as superior to the arterial blood gas for the detection of oxygenation and perfusion abnormalities. Continuous monitoring of mixed or central venous oximetry has, in many clinical situations, replaced venous blood gas analysis when monitoring for oxygen delivery impairment. The focus of this manuscript is to discuss the composite clinical value of combined and simultaneous arterial and venous blood gas analysis as an initial diagnostic strategy and as a powerful clinical decision-making adjunct during early goal-directed resuscitation in critical illness. Critical care medicine can be defined as a fusion of multiple and disparate medical specialties refined by applied bedside physiology whose ultimate goal is to improve overall morbidity and mortality in the acutely ill. Two cardinal principles define the diagnostic and therapeutic boundaries of the discipline. First, outcome from acute illness is a function of time from diagnosis to initiation of goal-directed therapy. And secondly, all current therapeutic endeavors attempt to contemporaneously improve oxygen delivery and minimize oxygen consumption. The oxygen delivery and consumption paradigm facilitates the patient's unique physiologic reserve and enhances the likelihood of recovery. There are three reasons why a clinician should obtain an arterial blood gas. The first is an oxygenation assessment. Second, assessment of ventilation. And third, evaluation of acid-base status. There are three reasons why a clinician should obtain a venous blood gas. Further assessment of ventilation and acid-base status, cardiac output assessment via the surrogate veno-arterial PCO2 difference, and also as an endpoint of resuscitation during early goal-directed therapy by measuring serially the central venous oxygen saturation, mixed venous oxygen saturation, and or the delta PCO2 difference, or the veno-arterial PCO2 difference. Notice that these physiologic measurements have augmented benefit when the arterial gas and the venous gas are drawn together. We will explore this further later in the discussion. This is a typical arterial blood gas report. Notice that the pH has no units. Its range of normal is 7.35 to 7.45. The PaCO2 in millimeters of mercury has a range of normal between 35 and 45. The partial pressure of oxygen in the arterial bed, also in millimeters of mercury, is a range of normal and room air of 110 minus 0.5 times age. The bicarbonate in millimoles per liter is a range of normal between 22 and 26. Notice that this is not measured but calculated. The base excess in millimoles per liter, a range of normal between -2 and 2, also calculated. The oxygen saturation, a range of normal greater than 90%, also calculated. The mixed or central venous blood gas report is somewhat different. The pH is mildly acidotic relative to the arterial bed, ranging between 7.32 to 7.42. The partial pressure of carbon dioxide in the venous bed is higher, between 40 to 50 millimeters of mercury, thus explaining the venous respiratory acidosis. Partial pressure of oxygen in the venous bed is lower as well. Normal range 36 to 42, with a normal oxygen saturation usually greater than 70%. The base excess approximates the arterial bed base excess, being -2 to +2. The analysis of ventilation is very simple in the human body. The partial pressure of carbon dioxide in the arterial bed is proportional to carbon dioxide production in the tissue bed divided by alveolar ventilation. Hypercapnia is defined when the partial pressure of carbon dioxide in the arterial bed is greater than 45 millimeters of mercury. Hypocapnia is defined when the partial pressure of carbon dioxide is less than 35 millimeters of mercury. Elevated CO2 is often associated with a respiratory acidosis, and a diminished CO2 is often associated with a respiratory alkalosis. Disturbances in respiratory acid-base status can be easily understood by changes in the first dissociation constant of carbonic acid, as illustrated. In the tissues, hydrogen ion and bicarbonate unite to form carbon dioxide, which then is transported to the lungs and released as carbon dioxide and water. Acute changes in the partial pressure of carbon dioxide by 10 millimeters of mercury result in acute change in pH by 0.08 units. Chronic change is approximated by 40 plus the base excess. Notice that the relationship of alveolar ventilation to carbon dioxide to pH. As alveolar ventilation goes up, carbon dioxide goes down, pH goes up. Again, a respiratory acidosis is when the partial pressure of carbon dioxide in the arterial bed is greater than 45. A respiratory alkalosis is when the partial pressure of carbon dioxide in the arterial bed is less than 35. Base excess is a tool used to measure the magnitude of a metabolic acid-base disorder. A positive value indicates excess base or a metabolic alkalosis. A negative value indicates excess acid or a metabolic acidosis. This measurement is pretty much PCO2 independent, and it is estimated by taking the total CO2 from a chemistry panel minus 25. It is obtained automatically when an arterial or venous blood gas is submitted. The classic method of performing problem solving of acid-base issues is presented. Initially, number one, we look at the pH. Whatever side of the pH 7.4 is on is the primary disorder. Number two, we look at the pH PCO2 direction. If both decrease or increase, then we have a metabolic acid-base disorder. If we move in opposite directions, we have a respiratory acid-base disorder. In terms of establishing the chronicity of the disorder, acute changes in respiration are associated with this relationship. A 10 millimeter mercury change in PCO2 is associated with a 0.08 change in pH. Chronic changes in respiration, 40 plus the base excess. Case example, a 74-year-old male found unresponsive and pulseless. Arterial blood draw, pH 7.28, PaCO2 34, bicarbonate 16. Sodium is 153. Chloride is 106, and total CO2 is 17. Saturation from the arterial blood gas is 84%. What is the primary acid-base disturbance? And what is the metabolic acid-base status? As stated before, from our algorithm for determining acid-base status, acidosis is present and acidemia because the pH is less than 7.4. The pH and PCO2 are both down in direction, and hence we have a metabolic acidosis. The base excess is negative 8 millimoles per liter, indicating the magnitude of the metabolic acidosis. A simultaneously performed venous blood gas was obtained. The pH was equal to 7.08. The PvCO2 was equal to 75 millimeters of mercury. The bicarbonate was 21 millimoles per liter. Sodium was 145. The chloride was 103. The total CO2 was 22. The albumin was 3 grams per deciliter. The venous saturation was 20%. What is the primary acid-base disorder, and what is the metabolic acid-base status? Again, because the pH is less than 7.4, there is an acidosis and an acidemia. However, the pH and PCO2 are now in opposite directions. Therefore, there is a respiratory acidosis. The base excess is equal to negative 2 millimoles per liter. So, in review, a 74-year-old male found unresponsive and pulseless. Question: why a metabolic acidosis in the arterial bed and a respiratory acidosis in the venous bed? How can we explain the large veno-arterial PCO2 difference of 41? Partial pressure of carbon dioxide in the venous bed was 75, and the partial pressure of carbon dioxide in the arterial bed was 34. This discrepancy is explained by a relationship between veno-arterial carbon dioxide difference, which is proportional to 1 over the cardiac index, which we will evaluate and discuss later. Normally, this value should be 6 millimeters of mercury or less. Also, why a veno-arterial saturation difference? The partial pressure of oxygen in the arterial bed was 50, with a saturation of 84%. And the partial pressure of oxygen in the venous bed was 18, or a venous sat of 20%. This is the increased oxygen extraction from circulatory failure. The slide reviews the sequence of events that occur in the partial pressure of oxygen in the arterial bed and the partial pressure of oxygen in the venous bed during cardiogenic shock. Notice that at the outset of cardiogenic shock, we see immediately the partial pressure of oxygen in the venous bed declining. However, nothing seems to be appearing in the partial pressure of oxygen in the arterial bed. As shock is established, the veno-arterial oxygen saturation difference has become quite large. As cardiac function is restored and perfusion is improved, the partial pressure of oxygen in the venous bed improves in tandem. I will also review the changes in the partial pressure of carbon dioxide between the arterial and venous bed. In shock, the partial pressure of carbon dioxide in the venous bed increases and the partial pressure of carbon dioxide in the arterial bed decreases, creating an evolving and increasing venous arterial CO2 difference. Also notice the arterial pH is alkalemic, but the venous pH is acidemic, which appears paradoxical. I will spend the next several slides discussing these phenomena. The oxygen delivery and consumption imperative is best conceptualized by a review of the Fick oxygen consumption equation. Notice that whole body oxygen consumption, VO2, is equal to 1.34 times hemoglobin times 10 multiplied by the cardiac output times the arteriovenous oxygen saturation difference. So, under the conditions of constant oxygen consumption, a VO2 that is constant, if the cardiac output drops, this must be accompanied by an increase in arteriovenous difference. We will also review the Fick equation for carbon dioxide production, which is no different than the Fick equation for oxygen consumption. VCO2 stands for carbon dioxide production in the tissue bed, and on basal conditions approximates 200 milliliters per minute. Carbon dioxide production is equal to 10 times the cardiac output multiplied by the veno-arterial carbon dioxide difference. If cardiac output decreases and carbon dioxide production remains constant, what must happen to the veno-arterial CO2 difference? A decrement in cardiac output must accompany an increase in veno-arterial CO2 difference at a constant carbon dioxide production. In 1986, doctors Grundler, Wheel, and Rakow published a remarkable manuscript evaluating the arteriovenous carbon dioxide and pH gradients during cardiac arrest. In their porcine preparation of cardiac arrest, these physicians demonstrated that there was a marked paradox of venous acidemia and arterial alkalemia. They demonstrated that the paradox is related to the decreased clearance of carbon dioxide from the lungs when pulmonary blood flow is critically reduced. Also, increased venous CO2 rather than metabolic acidosis due to lactic acidosis predominates during the initial 8 minutes of cardiopulmonary resuscitation. Their overall conclusion was that arterial blood gases fail as an indicator of systemic acid-base status and therefore as indicators of tissue acidosis. This slide is a review of a typical case example of porcine cardiopulmonary arrest. At the outset of ventricular fibrillation, notice that the mixed venous PCO2 increases. The arterial PCO2 decreases, creating a veno-arterial PCO2 difference. Also notice the pH on the arterial bed increases, creating an alkalemia, and the pH on the venous bed decreases, creating an acidemia. As ventricular fibrillation is corrected and resuscitation is initiated, the veno-arterial PCO2 difference melts away and acid-base status collapses to an overall metabolic acidosis. End-tidal carbon dioxide measurements reveal this paradox in a different way. When pulmonary blood flow is reduced during cardiogenic shock or ventricular fibrillation as induced during the study, carbon dioxide builds in the venous bed because ventilation is impaired. The carbon dioxide content of the breath exhalate will demonstrate a marked reduction, supportive of cardiogenic shock. As resuscitation is implemented and ventricular fibrillation is corrected, cardiac function recovers and end-tidal CO2 recovers as well. In 2005, Doctors Koshiri, Rivers, et al. Published a remarkable article in the journal Intensive Care Medicine titled Central Venous Arterial Carbon Dioxide Difference as an Indicator of Cardiac Index. The conclusion of their study was that veno-arterial PCO2 differences from pulmonary artery and central venous circulations inversely correlate with cardiac index. Substitution of a central for a mixed venous PCO2 difference provides an accurate and alternative method for calculation of cardiac output. Table 1 demonstrates the diversity of the patient population this study was performed on. Notice that it ranges across the entire spectrum of critical illness: hypovolemic shock, intra-abdominal sepsis, cardiac arrest, post-op myocardial infarction. Total number of individuals evaluated, 83. This slide looks at the relationship between mixed venous arterial PCO2 gradient versus the logarithm of cardiac index. Notice that as the mixed venous arterial PCO2 gradient increases from 6 to 7 to 8 to 9, the cardiac index diminishes. This is the natural logarithm cardiac index. The confidence bands are quite narrow. Further, if we look at the central venous arterial PCO2 gradient compared to the natural log of cardiac index, we continue to see a very close confidence interval with a marked loss of cardiac function as the central venous arterial PCO2 gradient increases. There is debate in the literature on whether the arterial venous PCO2 difference is secondary to hypoxic hypoxia or insufficient oxygen availability to the blood tissues versus ischemic hypoxia, circulatory collapse. In 2004, Dr. Gutierrez presented a very elegant mathematical model evaluating this question. In this model of tissue carbon dioxide exchange, the venous and tissue carbon dioxide increase during ischemic hypoxia, but not during hypoxic hypoxia. These results support the hypotheses that increases in tissue carbon dioxide and the arteriovenous PCO2 gradient reflect only microcirculatory stagnation, not tissue dysoxia. Thus, increases in tissue and venous PCO2 are insensitive markers of tissue dysoxia and merely reflect vascular hypoperfusion. In his mathematical model, the two separate at approximately a 15 millimeter of mercury difference between the arteriovenous PCO2. In 2008, an article published in the journal Intensive Care Medicine titled Central Venous to Arterial Carbon Dioxide Difference, an Additional Target for Goal-Directed Therapy in Septic Shock. In this study, in ICU resuscitated patients, targeting only SCVO2 may not be sufficient to guide therapy. When the 70% central venous oxygen saturation from goal is achieved, the presence of a partial pressure of carbon dioxide gradient larger than 6 millimeters of mercury might be a useful tool to identify patients who still remain inadequately oxygenated. What this study is suggesting is that we augment early goal-directed therapy to include the veno-arterial CO2 difference as an additional endpoint of resuscitation. In review, the veno-arterial CO2 difference obtained from a simultaneous arterial and venous blood gas is a surrogate measurement of circulatory failure. All forms of circulatory failure are associated with tissue hypercarbic acidosis. Examples where this may be relevant include hypovolemic shock, septic shock, cardiogenic shock. The equation presented can deduce cardiac index if the veno-arterial CO2 difference is known, and should be considered as an endpoint of resuscitation in critical illness. In review, a 74-year-old male found unresponsive and pulseless. We will now focus on the veno-arterial saturation difference. The partial pressure of oxygen in the arterial bed was 50 millimeters of mercury, with a saturation of 84%. Partial pressure of oxygen in the venous bed was 18, with a venous saturation of 20%. What we are seeing was the increased extraction from circulatory failure. This graphically illustrates the point. The partial pressure of oxygen in the arterial bed versus the partial pressure of oxygen in the venous bed in cardiogenic shock. Venous oxygen tension and saturation drop during cardiogenic shock, but the partial pressure of oxygen in the arterial bed remains unchanged initially. The arterial venous saturation difference is augmented, more oxygen being extracted from the venous bed during the metabolic stress of shock. During recovery of cardiac output, venous oxygen tension recovers as well. The point being made is that the partial pressure of oxygen in the venous bed and the central venous oxygen saturation change in parallel when whole body oxygen supply to demand is altered. So whole body oxygen consumption is equal to arterial oxygen delivery minus venous oxygen delivery. The difference represents the amount of oxygen consumed by tissues. Normally, at baseline, we consume approximately 250 milliliters of oxygen per minute, or 5 milliliters per 100 milliliters of blood. The oxygen utilization coefficient is 0.25, and the arteriovenous saturation difference approximates 25%. This cartoon illustrates the point. Oxygen is inspired at a partial pressure of 160 millimeters of mercury from atmospheric air. In the alveoli, it drops to 102 millimeters of mercury, secondary to water vapor pressure. It is picked up by the capillary bed and transported to the left atrium and left ventricle. The blood within the cardiac chambers reveals a partial pressure of oxygen of 94 millimeters of mercury. This continued drop is secondary to venous admixture. The arterial saturation is 97%. The hemoglobin is 15 grams percent. The content of oxygen is 20 milliliters of oxygen per 100 ml of blood. And the arterial oxygen transport is 1,000 milliliters of oxygen per minute, with a cardiac output of 5 liters per minute. Oxygen is then extracted in the tissue bed, as stated, at approximately 250 milliliters of oxygen per minute, or 5 milliliters of oxygen per 100 ml of blood. On the venous bed, content of oxygen is 15 milliliters per 100 ml of blood. The venous oxygen transporting total is 750 milliliters of oxygen per minute, and the venous saturation drops to 73%, secondary to the extraction of oxygen in the tissue bed. Partial pressure of oxygen in the venous bed is now 39 millimeters of mercury, and the cycle occurs again. The Fick equation for oxygen consumption is remarkably useful in the critically ill. Oxygen consumption is approximately 250 milliliters per minute, as stated earlier. The equation for oxygen consumption is 10 times the cardiac output multiplied by the arteriovenous oxygen content difference. If we further break down the equation, oxygen consumption is equal to 1.34 times hemoglobin times cardiac output times the arteriovenous oxygen difference. We then solve for the venous oxygen saturation. What we obtained are the four determinants of mixed venous oximetry. Mixed venous oxygen saturation is equal to the arterial oxygen saturation minus, in brackets, whole body oxygen consumption divided by cardiac output times hemoglobin. What we see here is that mixed venous oximetry is directly proportional to whole body oxygen consumption and cardiac output, and correlates well with the ratio of oxygen supply to demand. A decrease in mixed venous oximetry and central venous oxygen saturation represents an increased metabolic stress because oxygen demands by the body are not being met by delivery. Sustained tissue hypoxia, or low mixed venous oximetry, is one of the most important factors in the pathophysiology of organ dysfunction and ultimately cell death. The mixed venous saturation refers to the percentage of hemoglobin saturated with oxygen. It is a flow-weighted average of multiple venous saturations from all perfused vascular beds. It has four major determinants: the arterial saturation, the whole body oxygen consumption, cardiac output, and hemoglobin. It represents the physiologic oxygen reserve in times of stress. Venous oxygen saturation differs among different organ systems since each organ system extracts different amounts of oxygen. The heart has the highest extraction coefficient, and the kidney and skin the lowest. Notice we can define the limits of mixed venous oxygen saturation. If the saturation is greater than 75%, we have normal extraction and oxygen supply exceeds demand. If venous oxygen saturation is less than 75% but greater than 50%, this is compensatory extraction. We have increasing oxygen demand or decreasing oxygen supply. If the mixed venous oxygen saturation is less than 50% but greater than 30%, we are approaching the exhaustion of extraction. We see the beginning of lactic acidosis, secondary to anaerobic metabolism and the exhaustion of oxidative metabolism. If the SvO2 is less than 30%, we see the evolution of severe lactic acidosis and eventually cellular death. Why measure mixed venous oxygen saturation? A decrease in mixed venous oxygen saturation is an early indicator of a threat to tissue oxygenation. Earlier information results in earlier diagnosis with interventions, and the normal range of SvO2 is between 60 and 80%. Notice the multiple variables that affect the mixed venous oxygen saturation. All of these variables, by the way, are manipulated in the intensive care unit to improve patient outcome. Factors that increase whole body oxygen consumption, stress, pain, hyperthermia, and shivering. All of these will result in significant decrements in venous oxygen saturation. They are all legitimate targets in critically ill patients. Factors that cause diminished oxygen delivery include decreased partial pressure of oxygen in the arterial blood, hemoglobin, and a diminished cardiac output. Again, legitimate intensive care unit targets. Supplemental oxygen, transfusion, inotropes, and vasopressors. Factors that increase oxygen delivery include improved PaO2 by mechanical ventilation, supplemental oxygen, increased hemoglobin concentration by transfusion, and increased cardiac output by preload augmentation, inotropes, and vasopressors. Factors that decrease whole body oxygen consumption include analgesia, sedation, mechanical ventilation, and hypothermia. This slide reviews a time course of continuously measured central and mixed venous oxygen saturation in a patient with acute respiratory distress syndrome who developed a tension pneumothorax and was treated by the insertion of a chest tube. Notice that both the mixed and central venous oxygen saturations mirror one another quite closely and provides a real-time information system on metabolic stress. This slide reviews the multiple changes in both mixed and central venous oxygen saturation induced by multiple experimental manipulations, including hypoxia, bleeding, and fluid resuscitation. Again, both mixed and central venous saturations mirror each other quite nicely. In review, the master equation in critical illness is the central venous oxygen saturation approximates the mixed venous oxygen saturation, which is equal to the arterial saturation minus whole body oxygen consumption divided by cardiac output multiplied by hemoglobin. In acute illness, critical illness, or post-op surgery, SaO2, VO2, cardiac output, and hemoglobin are dynamically changing concurrently. Best medical care is to optimize each parameter and then recheck ScVO2 to assess the response of this intervention. Early goal-directed therapy algorithms are to be followed simultaneously. This graph illustrates the effects of changes of PaO2, or partial pressure of oxygen on the arterial bed, on mixed venous oxygen saturation. And notice that as the PaO2 drops below 80, we see a 1-to-1 linear relationship in drop in the SvO2. This chart illustrates the effects of changes in hemoglobin on mixed venous oxygen saturation. And notice that as hemoglobin drops below 10, significant decrements in venous saturation evolved. This placard reviews the effects of cardiac output on mixed venous oxygen saturation. And notice that as cardiac output drops below 4, venous saturation also significantly diminishes. This slide reviews the effects of oxygen consumption on mixed venous oxygen saturation. Normal basal oxygen consumption is 250 milliliters per minute. If oxygen consumption, for example, is doubled to 500 milliliters per minute, significant drops in mixed venous oxygen saturation evolve. Hence, the primary treatment of critically ill hyperdynamic patients is sedation, analgesia, and a reduction in oxygen consumption to improve SvO2. So, in review, central venous oxygen saturation allows early separation in early versus late shock. It's easily measured with a venous blood gas. The central venous catheter site usually resides in the superior vena cava, and thus central venous sampling usually reflects the venous blood of the upper body, which is the preferred site at this time for serial measurements. It is a surrogate measurement of mixed venous oxygen saturation, often 5 to 18% higher. However, of critical importance, a low central venous oxygen saturation always means a low mixed venous oxygen saturation. And a normal central venous oxygen saturation is 68 to 76%. This chart again reviews the tight relationship between central venous and mixed venous oxygen saturation. In 2001, a landmark study was published in the New England Journal of Medicine titled Early Goal-Directed Therapy in the Treatment of Severe Sepsis and Septic Shock. The study revealed two main outcomes. From 7 to 72 hours in the early goal-directed therapy group, higher mean central venous oxygen saturations were obtained, lower lactate concentrations, lower base deficit, and higher pH when compared to the standard therapy group. Final conclusion was that early goal-directed therapy provided significant benefits with respect to outcome in patients with severe sepsis and septic shock. This is an example of the early goal-directed therapy algorithm, as published by Dr. Rivers et al. The main innovation of this algorithm in resuscitation for severe sepsis, septic shock, was the emphasis on both microcirculatory and macrocirculatory endpoints of resuscitation. The microcirculatory endpoints of resuscitation focus on the venous blood gas with lactic acid elevation. In 2006, the concepts, controversy, and contemporary findings of early goal-directed therapy in severe sepsis and septic shock were revisited. Conclusion: studies of acute myocardial infarction, trauma, and stroke have been translated into improved outcomes by earlier diagnosis and application of therapy at the most proximal stage of hospital presentation. The endpoints used in early goal-directed therapy, the outcome results, cost effectiveness have been externally validated. In summary, simultaneous arterial blood gas and venous blood gas analysis provides an initial assessment of oxygen delivery and consumption state. Serial measurements provide additional information on the adequacy of interventions. An arterial blood gas provides information on oxygenation via the alveolar gas equation, on ventilation via partial pressure of carbon dioxide in the arterial bed, and acid-base status via pH, PCO2, bicarbonate, and standard base excess. A venous blood gas, either mixed or central, provides information on oxygen extraction ratio, mixed or central venous oximetry, and the veno-arterial CO2 difference for cardiac output. Case example. 65-year-old man presents to the emergency room in shock. Blood pressure 60/30, heart rate 150 beats per minute. He is pale, cool, dilated pupils, semi-comatose with low urine output. Two possible causes of low blood pressure were considered: cardiogenic shock and hemorrhagic shock. A simultaneous arterial gas and venous gas was obtained. Case example number 1. pH, arterial, 7.25, PCO2 30, PaO2 75, saturation 97%, base excess negative 15, lactic acid 15. Venous blood gas, pH 7.20, PCO2 36, PVO2 25, venous saturation 45%. Veno-arterial CO2 difference equal to 6, normal. Lactic acidosis with a diminished venous saturation are consistent with hemorrhagic shock. Example 2. Arterial blood gas, pH 7.30, PCO2 25, PaO2 50, base excess negative 10, saturation 85%, lactate negative 10. Venous blood gas revealed 7.20, PCO2 50, PVO2 25, venous saturation 45%. Veno-arterial PCO2 difference of 25, markedly elevated, consistent with the underlying diagnosis of cardiogenic shock. Additional references for review. Thank you very much.